There you go. Okay.
So, we're talking about AFib with RVR, right? So you should be aware of this because this is going to have you decide what they can do anticoagulation for the patient for stroke prevention. It's not very hard to be candidate for stroke prevention, right? You only need at least 2. So there's so many options in there that you're going to score 2 very quickly, okay? Who's going to tell you if the patient is safe to be taking anticoagulation? Which score? Hasbled, okay? So Hasbled is going to tell you, depending on the patient's age, comorbidities, response to your anticoagulation, whether he's a candidate for this or not. Basically giving you the risk for major bleeding, right? And you compare the two, seeing the benefit. Common sense will also tell you if the guy is an active alcoholic, if the guy has a history of seizure, if the guy basically is a risk of falls in the most unexpected places and situations, then you probably should reconsider your anticoagulation therapy and maybe just do aspirin. Okay? Okay.
A quick question.
Yeah.
So with these newer anticoags, could we be more aggressive? I mean, those scores were probably based on warfarin versus aspirin versus nothing.
Mm-hmm.
With the newer abigatron and this one, nothing has been approved for AFib.
Yes. Yeah, you can do this.
So could we be more aggressive, or would we still be?
I don't think there's any study that shows. It showed most of the studies that showed is non-inferiority and basically being as efficient as what we used to do before.
And the bleeding events, are they?
Well, the bleeding events used to be when they show up, then you can't fix it basically, right? You have a shitstorm on your head if you end up with somebody bleeding on anticoagulation, right? Well, on the newer factors. But now they're coming up with antidotes, so you can be okay.
Right, they didn't have antidotes.
Yeah, yeah. Okay. But I would still use common sense, even if we're safe, sort of safe, so speaking, because like I've been long enough in this hospital to know that, and my example with alcoholics, right? They go out of the hospital, we treat them for whatever, an alcohol withdrawal, and guess what? By evening they're back. They're being picked up from the parking lot, they just hit their head. And I have patients with intracranial hematomas and super bleeds, not even being on anticoagulation. But imagine if they did. So you gotta think twice. Yeah. In certain scenarios, use your clinical judgment. Okay. All right. So we speak about AFib with RVR. So there are a couple. What medication we can use for AFib? To control the heart rate, right? This is RVR. Try to control the heart rate. There's so many things you can use, right? So there's beta blockers, calcium channel blockers, digoxin. Okay. So you have quite an arsenal. Treatment of choice for the guy that has systolic heart failure and now comes with AFib with RVR is what? Digoxin, right? You should use digoxin unless this is contraindicated. Just remember that if somebody has active ischemia, or there's a history that makes you worry that the guy may have an acute coronary syndrome, digoxin it's a positive inotrope, so it increases demand. So have all those things thought through, okay, before you start any new medication, okay? So, how do you fix AFib? Like the question, which is classic, right? Should you control rate or rhythm? Should you reestablish rhythm for AFib or not? What's the
rate people like to get that should have rhythm.
All right, so we don't strive to reestablish rhythm control, okay? Because it's as good as, unless the patient is very symptomatic, unless the patient has really bad heart failure, and they depend on some atrial kick, right? So maybe then you will try to reestablish rhythm. And we'll talk about what that procedure is used for that. What about a flutter? We have a flutter, right? So a flutter, usually we see the guy at, so any regular narrow complex tachycardia at 150 is a flutter until proven otherwise, right? It's usually 2-to-1 block. What do you see? Like if I put an electrode in the atria, you're going to see this, right? The sawtooth crap, F wave, that's what they call, right? So if you're not sure if you're seeing F waves, what are a couple of things you can do? If you're not sure, like on EKG, maybe this gets buried or hidden, like you're seeing Q wave, right? And maybe you don't see the F wave because it comes on top of the T wave and you're not sure the 2-to-1 block. What else you can do for these people?
Slow the rate down.
How?
Adenosine or carotid.
Okay, so any vagal maneuvers or AV nodal blockers can help you to differentiate this and go from 2-to-1 to 3-to-1 or 4-to-1 block, and it's going to be easier for you to see these ones in between. All right? Do you do chest gas score for this guy's A-flutter?
Yes. Yes.
Yes, yes, no, yes.
Yes.
Yes, yes, you do, okay? The same thing. Now, talking about fixing them, fixing AFib and A-flutter, let's do a little heart again. Where is A-flutter originating from? Right atrium, left atrium? Right atrium, okay? So, it originates at the isthmus. Most of the A-flutter is isthmus dependent. Very few instances in that it's not related to that, right? So it's between the inferior vena cava and the tricuspid, and this is the little isthmus right here, and just goes around like this at 300, which with one block, so you have a ventricular rate of 150. How easy is this to fix for an EP guy? I think it's fairly easy, all right? So the guy who's an EP guy, all right, he goes with a cath, goes here, and then he burns this thing, if it's isthmus dependent. And the success rate for this thing is pretty high, 90% or so, okay? For the AFib, where does AFib go?
Around the pulmonary veins, like left.
Around the pulmonary veins, right? So you have 4 pulmonary veins, bam, 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 bam. All right, so the guy, it's a little more complicated, right? Because you need to go in the left atrium, and then you need to burn around these. Right? How successful is that? So this is pulmonary vein isolation. Not very. Okay? Not very successful. All right? Because anytime you end up with scar tissue in the heart, that becomes a new foci for
Arrhythmia.
well, arrhythmia. Arrhythmia. No, exactly. Thank you, sir. Okay? All right, so this would be easy, and you probably send the patient to cardiology and try to fix it easily. This one, depends. You think twice. All right, let me see. Am I missing anything else? Sinus. All right, so we spoke about most of them. The other one is wandering pacemaker, or MAT. Who gets this? COPD patients, right? Lung disease. And what do you see? What's the definition of this? You should see at least 3 morphologies on EKG. So that means the 1P is going to look like this in the same lead, right? The other one is going to look like this. And the other one is going to look like this. Okay? 3 different morphologies, okay? So that's wandering pacemaker. How do you treat this? Treat the underlying disease, okay? All right. Now going down the EKG, the next one to look at is PR interval. So PR interval, what can happen with the PR interval? PR interval in duration, right? All right, in duration can be short, can be long. And in terms of level, it can be depressed. Okay, needs a psych consult. So if it's short, then we're talking about what? God, this guy, check him out. WPW, right? So basically, short PR, pre-excitation syndrome, right? Classical of Ken and all that bullshit, okay? So WPW, so you have a short PR, and what else? A delta wave, right? So you have this, and then bam, bam, bam. That's your WPW, okay? As I told you before, how many delta waves do you need to identify in EKG? 1 is good enough. You don't need to see it in all leads. You just have to suspect it. So if somebody comes with syncope, you have to consider WPW, okay? What's the antiarrhythmics you use for this?
Flecken.
Yeah, so 1C, I think,
1C,
right? So just, if you have somebody syncope and you think he has WPW, the first thing you do, you start crying and call cardiology, all right? Or the other way around, whatever, okay? But call them so you have them on board from the beginning. Another thing is, I want to mention, has nothing to do with EKG. The same goes for a Jehovah's Witness that has active bleeding. All right? How many have you dealt with that, Ella? You did? Okay. It's not pleasant, right?
No.
It's challenging. So what you should do? Well, you do what you can, and then you call hematology. Again, you cry on the phone, tell them, I need help with this. All right? And they'll tell you.
And you call ethics.
And you call ethics, but if they can prove they're Jehovah's Witness active, they go to the church, they have their whole church showing up, then, it's valid, and you have to respect that. But some people will lie to you about their refusal, whether they're being Jehovah's Witness or not. Bottom line is this: if you do have a patient coming in with hemoglobin of 5 and is still actively bleeding, have hematology involved from the beginning. All right? So, you know, have your back covered. PR prolonged. When you have a PR prolonged, then what's a normal PR basically?
Less than 200.
PR
120 to 200.
120 to
200.
200 milliseconds. All right. So if it's less than one big box, we're good. If it's more than one big box, then we're talking about AV block. So the first one is first degree AV block. All right. More than 200 milliseconds. Fixed. Fixed doesn't change. Who can give you first degree AV block?
Don't treat unless something symptomatic.
Very good. But what can give you first degree AV block? What can give you first degree AV block?
Sympathetic tone.
Okay. All right. So you can see it strangely in somebody who you're massaging their carotids, and you don't realize that actually you've been doing it for 2 minutes, right?
Yeah.
Okay. What else? Anything that can mess around with the AV node, the same thing. Beta blockers, calcium channel blockers, digoxin, right? Anything that can mess up with the AV node. Okay. Since we're talking about AV block, second degree AV block. Second degree, all right. So we have Mobitz 1 and Mobitz 2. All right. So Mobitz 1 happens what? With Benkeback periods, right? Progressive lengthening of the PR interval until the beat drops, right? So you have this. We have this, we have this, and then P and no B. Okay? And then this one, who actually has a constant PR interval, and then all of a sudden there's a P and no B. Which one